Good day. Thank you for joining us for our Health Matters webinar, What's at Stake as Rural Hospitals Lose as Rural America Loses its Hospitals. I'm Michelle Levander, and I'm the Director of the Center for Health Journalism. We are offering this webinar thanks to the generous support of the National Institute for Healthcare Management Foundation and the Commonwealth Fund. Rural communities have faced a growing number of challenges in recent years. There's the weakening of pillars of economic support that have led to high unemployment, dwindling populations and aging populations, and a disproportionate toll when it comes to both chronic diseases and the opioid epidemic. The closures of rural hospitals across America have only deepened that crisis, leaving communities without an anchor for healthcare services, emergency care, and jobs. Yet while this trend has accelerated, research on the topic has only begun to capture the depth of the problem. We'll focus today on how rural hospital closures affect childbirth, but we see equally rich opportunities for reporting and research on other ways that hospital closures affect entire populations. Participating in this webinar, we're fortunate to have a leading researcher and a key journalist who are both expert on these issues. Dr. Katie Kazimano is the Director of Research at the Rural Health Research Center at the University of Minnesota, where she's also an Associate Professor of Healthcare Policy and Management. Her research focuses on the ways in which health policy can improve healthcare delivery, quality, and outcomes during critical times such as pregnancy and childbirth. She is the author of a seminal research report published in the Journal of the American Medical Association last year on the negative impact of hospital closures on childbirth outcomes in rural communities across America. Our other speaker is Betsy McKay, a senior writer for the Wall Street Journal. She's a member of the team of journal reporters awarded the 1999 Pulitzer Prize in International Reporting for in-depth analytical coverage of the Russian financial crisis. She has won awards for stories on public health issues, including drug-resistant tuberculosis and maternity care in the rural U.S. She co-authored a series of stories for the Wall Street Journal, One Nation Divisible. Her reporting for the series focused on the challenges facing rural America, with a focus on how hospital closures affect and endanger childbirth in rural areas. We have several hundred people on this call, so let me just share a few operating instructions. Should you have technical issues or you want to ask a question, please use the control panel on your dashboard to do so. We'll hear from our two panelists first, and then we'll open it up to your questions. Should you want to tweet about this webinar, you could do so using the hashtag #RuralHealth. We'll be archiving this webinar for your future reference. And now we'll turn to Dr. Katie Kazimano. Paint a little bit of the landscape here of what these rural hospitals and rural communities are confronting.
Thank you so much, Michelle. And thank you all for joining us today to have this discussion. I really look forward to talking with you about some of the findings of our research and how these fit into a broader picture of the health, well-being, and vitality of rural communities. I think there's a wonderful way that research and journalism can work together to reveal broad patterns and individual stories in rural America. So my name is Katie Kazimano. I'm the director of the University of Minnesota Rural Health Research Center, and I'm going to tell you a bit about our research and about stories around the effects of rural hospital closures on childbirth in rural America. Brief overview. I'm going to focus first on our research, on why we did the research and what we found, as well as some of the media interactions that we've had, although I won't go into great detail there because Betsy will tell more about her perspective. I am also going to kind of zoom out and talk a little bit about telling the rural story and some guidance based on my experience of conducting research in rural communities, as well as some resources that you may not be aware of. I hope you are, but if not, you will be by the end of this discussion. At the University of Minnesota Rural Health Research Center, our mission is to conduct policy-relevant research to improve the lives of rural residents and families, to advance health equity, and to enhance the vitality of rural communities. We conduct research on a variety of different topics. Our research center is primarily funded by the Federal Office of Rural Health Policy at HRSA. And every year we do 4 different one-year research projects. And this is a sampling of some of the projects that we've done recently. I'm going to focus on one which looks at obstetric unit and hospital closures and how that affects maternal and infant health in rural communities. Before I tell you what we did and what we learned in this research, I want to tell you why we did it. There are 18 million reproductive age women who live in rural U.S. communities. There are similar populations of other groups of interest, and it's important to know how many of us live and come from rural America. There are 500,000 babies born in the rural USA every year, and we know that there's a declining trend in access to hospital services generally and to obstetric services specifically. There was a group of women in rural Alabama in 2015 that asked their member of Congress, Representative Terry Sewall, if what they were seeing in their communities was unique or if it was part of a broader pattern. These were moms in predominantly Black communities of rural Alabama that were seeing their hospitals close their obstetric units and were having to travel further and further to give birth to their babies. There were mothers and grandmothers and aunts who saw what was happening on a community level and raised some alarm and concern about this. So their congressional representative called the National Rural Health Association and asked them if there was any evidence about this. The National Rural Health Association called me, and I said, actually, we don't have good updated information about this in the United States right now. And I cited some studies from other countries and some research from the 90s, none of which really reflected on the experience of women in rural Alabama at that time. So with the support of the Federal Office of Rural Health Policy, we embarked on a project to better understand rural maternity unit closures across rural America. So before I go into the maternity units specifically, I know this webinar is focused broadly on rural hospital closures, and I want to briefly discuss sort of the 3 main reasons that we know both from quantitative research and from qualitative evidence and anecdotal evidence about why rural hospitals are closing. And the first is financial constraints. So to keep a hospital's doors open and to be ready to take care of a patient at a moment's notice, there are fixed costs. You need to have not only like the building available and the lights on, but you got to have the right people in the building to take care of the patients that walk through your door. And so there are fixed costs that are constant, but the revenue to pay for those costs comes with every patient that walks through your door. And when you are in a rural and remote area, there are fewer people walking through your door, generally, if you're in less populous areas. And so the revenue is variable and it depends on volume. It also depends on who covers the health insurance, if the patient who walks through the door has health insurance, and if so, what kind. In the field of childbirth is about half of all births in the United States are funded by Medicaid, and that percentage is higher in rural hospitals. Medicaid also pays about half of what private health plans pay for birth. And so the number of people that walk through the door with a particular type of payer also matters for that bottom line. So Medicaid plays a really important role in financing rural hospitals. Workforce constraints are also important. We hear a lot about physician shortages in rural communities, and that is important and a clear constraint on rural hospitals' ability to operate. However, it's not just doctors that are in short supply in rural communities, but also nurses and administration. And so there's broad workforce constraints that affect the ability of rural hospitals to stay in business. And finally, there are also important patient safety concerns. And this comes when clinical teams that take care of folks are concerned about their ability to provide high quality care to a wide range of patients with a wide range of problems. In general, folks in rural communities are older and sicker than those that are in urban communities. We've seen the opioid epidemic disproportionately hit rural communities, And that creates clinical complexity that can add to the emotional burden, the financial burden, and the clinical care burden that rural hospitals have. I also want to point to a useful tool from my colleagues at the Shep Center at the University of North Carolina, the Rural Hospital Closure Tracking. The link is available here, and my colleagues there have been tracking rural hospital closures generally across the United States and have done great research on predictors of rural hospital closures, including a lot of information about hospital finances. So when we look at what happens in a rural community after a hospital closes, there's a growing body of research on this, and sometimes we see the consequences are mixed. There's a study that was linked to in the materials for this webinar that showed no mortality effects of a rural hospital closure within a hospital service area among Medicare beneficiaries. So it was a very well-conducted study, but it defined a rural community as a hospital service area, and the exposure was one hospital closure in there. We don't know if there were other hospitals. I mean, there might have been other hospitals, and it's unclear if that, what's the right way to look at a community. And these are the kinds of questions that we struggle with as researchers, but the journalists can sometimes take a more nuanced look at. So I'll dive into our work now. The main question that we started with is looking at how many rural communities lost hospital-based obstetric services. And I'll say right away that the communities that we were looking at in our research were based on county. And I also want to acknowledge the limitations of that. Counties vary in size. They're small in Alabama, and they're quite large in parts of rural California and rural northern Minnesota, Nevada, Arizona. So we looked at counties, and we looked at during the most recent decade for which we could get available data at the time we conducted this research, how many rural communities lost services. And you can see here the percent of rural counties with hospital obstetric services are divided into micropolitan and non-core counties. Sometimes in conducting research and in doing journalism on rural communities are swept with a broad brushstrokes that don't necessarily look at the nuance and diversity within rural communities. There are micropolitan communities that have small towns, and there are non-core areas that don't have a core urban center at all, and these are tend to be more remote communities. What we found is that overall, micropolitan communities were much more likely to have rural obstetric services, and the declines that we saw were primarily concentrated in non-core areas, so the more remote rural communities. Shown another way in a map, you can see here we basically mapped all counties in the United States. The urban counties are in white, and then all the rural counties are mapped by whether they did not have any obstetric services in 2004, whether they lost hospital-based obstetric services between 2004 and 2014, or whether they had continual access to services. And these are just multiple ways that we shared these data. We also looked at what the characteristics of communities that had greater vulnerability to losing hospital-based obstetric services. Overall, we found that more than half of all rural counties had no place where someone could give birth by 2014. 9% of rural counties lost hospital-based obstetric services during the decade we studied. And interestingly, we found that the rural counties that were most susceptible to losing their services were counties with a higher proportion of low-income residents, those that had fewer obstetricians or fewer family physicians, those that were in remote non-core areas. Interestingly and importantly, holding all else constant, rural communities with a higher proportion of Black residents that were reproductive age women were more likely to lose hospital-based obstetric services, and also communities that are located in states with less generous Medicaid programs. If you look at the demographics of the women in rural Alabama who raised this question in the first place, they were exactly right. Their communities were the communities that were the most deeply affected. And it was so important to me as a researcher to be able to to ask a question that came from a community and to be able to deliver an answer that acknowledged the wisdom in that community. The next and most important question that came here is not just where are these closures happening, but what are the consequences? And what we did here was we looked at these counties that lost hospital-based obstetric services entirely, and we looked at 3 different major outcomes. We looked at where babies were born. We looked at whether there was an increase in out-of-hospital births, and these could have been planned or unplanned out-of-hospital births. We looked at births occurring in hospitals that don't have obstetric units. So these are births that are predominantly occurring in emergency rooms. And we also looked at preterm birth, or birth before 37 weeks gestation. That's an important outcome because preterm birth is the leading cause of infant mortality in the US. And we know from CDC statistics that rural infants have a higher mortality rate in the first year than urban infants. What we found is that the effects of losing hospital-based obstetric services in rural communities were concentrated in rural counties that were not adjacent to urban areas, rural counties that were more remote, that were not next to an urban county. And we found an increase in births that happened outside the hospital, births in emergency rooms, and in preterm birth in these communities. In rural counties that were located next to urban areas, we did see an increase in births in emergency rooms, but that increase declined over time. So there was somewhat of a learning curve where folks were probably going to their local hospital that had closed their OB unit until systems were worked out and put in place to bring folks into hospitals that did have obstetric units. That same decline did not occur in rural communities that were more remote. That increase that happened after closures was sustained over time. We published these findings in the Journal of the American Medical Association on March 8th of last year. And on that same day, my colleague Carrie Henning-Smith was able to present the findings at a congressional briefing about the Improving Access to Maternity Care Act. This piece of legislation, which defines maternity care shortage areas, much in the same way that we look at primary care shortage areas and health professional shortage areas, was passed and signed into law in late December of 2018. So this work has directly informed some current policy. And in addition to our ability to translate our findings into the policy sphere, working with media to talk about the essence of these outcomes, of these birth stories. Like, we looked at large patterns, but what does that really mean? What does it look like in different rural communities? The partnerships that we've had with the media have been essential. Developing relationships with reporters and with communities has really helped us to translate our findings into the real world and also into language that real humans understand. Some of the words that we use in our academic research are not accessible to everyone. And so working with reporters in various types of media coverage, including online, social media, newspaper, print, radio, TV, and magazine reporting, really helped us engage with everyone from national media also to local media that were telling the stories in their own communities. One example comes from the fabulous Betsy McKay, who you will hear from shortly in the series that she worked on and the story that she told. And I won't say anything more about this other than it was such a joy to work with Betsy on this story that she did that is absolutely breathtakingly beautiful and heartbreaking. And as a researcher, to get to work with a journalist to learn and understand the story of one woman, Whitney Brown is someone that I think about all the time in my work, and it's a gift to me to have had a chance to work with Betsy on this story. So I will pivot now just to the broader, I'm going to zoom back out and talk about some takeaways for journalists that are covering rural hospital closures and rural health generally. And my first plea, you're here obviously because you care about these issues, but please do it. Please tell rural stories. Rural stories matter. They're eloquent and beautiful and get to the heart of things in the way that research never can. And journalism is sometimes the first or the most catalytic lens on key issues that policymakers don't always see. Most of the policymakers, certainly our policymakers at the federal level, even if they come from rural states, have spent most of their adult lives in urban communities and are living in urban communities. Also, most of the research that's conducted on health and healthcare and healthcare delivery is at academic institutions in urban settings. So journalism is really so unique in how it can center in rural voices and rural communities. Also, many of the stories about rural hospitals focus on doctors and physicians, or on the finances, or on malpractice, and it's usually so much deeper than that in a rural community. When we first started doing work on rural maternity unit closures, I sent out a survey, or I sent actually a letter to all of the rural hospital administrators in 9 states, and just to tell them that we would be following up with a phone call to do a survey of around obstetric services. And I actually had hospital CEOs get that letter in the mail and pick up the phone and call me and talk to me about the difficulty in making decisions around keeping their obstetric services open. And when we conducted that survey and called all those hospitals, we got an 86% response rate because people wanted to talk to us. So I think there are resources, and there's a great willingness to talk about these issues that are happening in rural communities. Also, sometimes people look at rural communities with a sense of sadness for what they've lost or what they don't have that rural communities do have. And I think in sometimes focusing on the sad stories, it's also important to show the resilience, the strength, the beauty, and the courage of rural people and how they persevere, and how health can be a wonderful thing in rural communities as well. There is evidence out there. I direct one of 7 rural health research centers across the country, and our publications are available on the Rural Health Gateway. I'll show that in the upcoming slides. So there are a number of resources that are available. One key resource is called the Rural Health Information Hub, RHI Hub. One of the great tools that they have is a thing called Am I Rural? I have an arrow pointed here to where that is on the website. If you're wondering about whether the hospital that you're reporting on or the community that you're reporting on is considered rural by these definitions that we use in research, feel free to click on that link and put in your zip code or address, and you can find out. There's a lot of great information on RHI Hub, including evidence-based toolkits, which are written for communities, but may also provide helpful background material for reporters that are doing stories on rural health topics. This is all rural health and rural specific. So again, for getting the rural angle and aspects, these may be helpful tools. I mentioned the rural health research centers that are available across the country. There may be a rural health research center that's located near you. Our focus is on national research, although some of our centers also do locally engaged work as well. So that's a great source of research and information. All of the publications and products that come out of the Rural Health Research Centers are published on the Rural Health Research Gateway. The website is listed here. And the final key resource that I want to highlight is the communities. The people in rural hospitals, clinics, rural governments, and organizations, they tend to pick up the phone if you call. And it's also important to know that while many of them will speak with you, when they talk about something that's deeply moving and important to them, what they share with you, if it becomes public, it stays with them long after the story fades from the headlines. And so I think I have learned a lot of humility of going into rural communities and telling rural stories and doing rural research, because I go back to the university, I go back to my office, and I move on to the next project. And what I have talked to them about may have been the most pivotal moment of their lives, and they will remember it forever. They will also remember forever the respect that I show them, the tenderness that I have, and humility that I have in the face of something that was deeply important to them. So just a note that I wanted to add as well. That is all I have for you. Thank you for sticking with me, and I understand we will turn to Betsy, but I welcome any questions later on.
Thank you so much, Dr. Katie Kazimano, for this very moving presentation. We're going to turn now to Betsy McKay of the Wall Street Journal. Betsy, how did you approach this broad trend as a journalist and turn data into storytelling?
Well, thanks, Michelle, and thank you, everybody, for tuning in, and thank you, Katie, for that wonderful shout out about my story. I thought what would be most helpful for everybody today is to walk through that story and briefly through two others. I wrote these all in 2017, out of an interest in the dearth of obstetric care in rural areas. So how did I come to this topic to begin with? Well, I literally was raised in a rural healthcare situation. I grew up in Vermont, and we always had to drive a long way for healthcare, sometimes on roads like this. Thought I would show this since this is the weather that many of us are experiencing around the country right now. When I broke my arm one winter, my father had to drive me an hour and a half through the snow to a hospital to have my arm set because it was a complicated break. I mean, having to go a long way for some health needs has long been a feature of rural life, but now the situation has gotten worse. Now you have some of the most basic medical needs, like giving birth, disappearing from rural areas. I was living in Atlanta at the time. I live in New York now. And a couple of years ago, 2-3 years ago, I started to see stories about closures, reports about closures or potential closures of rural hospitals in various media there. It had become a real political issue because the state was not planning to expand Medicaid under the Affordable Care Act, and rural hospitals were affected by that and the other factors that Katie cited. So somewhere along the way, I think late 2016, I also heard about women as part of this having trouble getting prenatal care in a particular part of Georgia, southeastern Georgia, where many hospitals or maternity wards have closed over the years. And in fact, several years ago, Georgia was cited as having the highest maternal death rate in the country. So I was attuned to issues related to pregnant women. At the time, I was actually covering the Zika epidemic, and so was just very aware of issues like this. So after the Zika epidemic had died down, I started looking into this issue. I thought it was really interesting, and the extent to which prenatal care and places to give birth, I wanted to know how much they were disappearing from rural America rather than the area that I had seen. So first I needed to understand the scope. How common were these so-called, we started calling them maternity deserts around the country. I talked with researchers who had analyzed maternal death rates, who were studying rural healthcare. I talked with OBGYNs. I talked with administrators of rural hospitals, who, as Katie mentioned, are often very eager to talk. Many are struggling to find ways to serve their patients. And they have not only obstetric services closing, but other services as well, other really critical services. So there appeared to be two issues. One was that rural hospitals were closing obstetric units because they're expensive to run and the number of women giving birth in rural areas has gone down. And the second is that hospitals themselves were closing with all their services. So either way, if you're in one of those areas, you're losing your service. So one of the first researchers I reached out to actually was Katie, who was a great resource. I encourage you all to get in touch with her. She had just published a policy brief that I think led to with the data that she herself cited in her presentation. I was very interested in her data, finding that these that the percent of rural counties that lacked hospital OB services was rising and was now more than half of all rural counties. So my editors and I decided that we wanted to do two things. We would profile a woman. This is the story that I eventually did. And let me walk you through how I did it. So we decided we would profile a woman or women. We weren't really tied to whether we would do one or more in rural areas who had bad outcomes in childbirth, a serious complication or a death. And then the second thing we wanted to do was use data in the story and along with the story to show how this access to obstetric services had worsened over the past 15 years or so. So for that, I worked with my colleague, Paul Overberg, who has been on these webinars before and knows demographic data like the back of his hand. So first, to find patients, I tried several sources. I kind of reached far and wide. I asked doctors, nurses, researchers like Katie, other researchers, the National Rural Health Association. I reached out to support groups and associations for birth complications, the Amniotic Fluid Embolism Foundation and the Preeclampsia Foundation. And I looked on social media, Facebook, Twitter, GoFundMe, and other web sources. And we also use this data analysis that I'll describe in a bit to identify rural hospitals that had closed maternity wards. So I was able to use that to look for women and doctors geographically. So as a result of that, I spoke with several women and families all over the country who I found through these various sources. My editors and I decided finally that we should focus on one dramatic case. You know, all this time we had been thinking, do we focus on the, you know, several women, one woman, maternal mortality, or birth complications. We decided to focus on the most, you know, a case of a mortality. So that led us to the story of Whitney Brown, a 28-year-old woman in McMinnville, Tennessee, pictured here, who developed an amniotic fluid embolism while giving birth to her first child. So AFE is a rare complication. You know, someone in an urban hospital can also die of it. But her story illustrated the problems we were highlighting, that rural hospitals either don't have maternity wards or access to specialists at a time when young mothers in rural areas have more health conditions that potentially put them at risk. You know, obesity rates are higher, diabetes, possibly drug use. And so when Whitney started having complications giving birth in her local hospital, her medical team spent hours trying to get her stabilized and transferred to a larger hospital in Chattanooga, which was about an hour and a half away. The weather was bad, so no helicopters would fly. They had to wait for an ambulance because only a couple of ambulances are allowed out of the country at one time. And so, you know, one thing led to another. Many women, I should say that many women and their families do not want to talk about a maternal death or even birth complications. These are huge family tragedies. When you're dealing with a family in a rural area, they're also in a small town. They might not want people to know. They might not want to share misgivings about what happened if it involves other people in the town. So it takes a lot of sensitivity and a lot of work. I'm very grateful to Whitney's family for sharing her story and patiently helping me report the details. So for the data we used in the story and some charts that we ran with it, we examined mortality statistics in the CDC's Wonder database of public health data. So we calculated rates of death during pregnancy and postnatally annually from 2000 to 2015 and broke them down by 4 levels of urbanization, which you can see in the different colors in the chart. So the CDC's National Center for Health Statistics uses this urban-rural classification scheme for counties, which is based on, you know, delineation of metropolitan statistical areas for anyone who doesn't know this. And NCH has set 6 levels of urbanization. Paul combined them to create 4 so that the rural areas combine both the most rural and the micropolitan areas. But anyway, we ended up, the greatest difference we found, the analysis showed that more women everywhere are dying during pregnancy and from postnatal complications in 2015 than in 2000, but that the rates had risen the most for women in rural areas. It was 64% higher than it was in the cities. Next, we analyzed, and this is the analysis I referred to earlier, we've analyzed hospital cost reports filed to the Centers for Medicare and Medicaid services to see how many hospitals and which ones had stopped offering obstetric services between 2005 and 2014, which was the last year in which full data were available at the time. We found nearly 500, both in urban and rural areas, and we put the findings on a map so that everybody could see, readers could see where hospitals are closed. And this is the data that I used also to search for, hospitals to talk to. Third, we were able to get some data from the American Medical Association's Physician Master File, which is not publicly available. We had an agreement with them and analyzed it against demographic data to show the number of OBGYNs, per population of women age 15 and older. And so it showed a dearth in rural areas. So it took weeks of work to crunch all this data, all to get boiled down into a few paragraphs and charts, but it was really worth it because we were able to document a trend. And as Michelle mentioned, this story was part of a series that we did at the Wall Street Journal on the rural-urban divide called One Nation Divisible. And you can get to all of the stories from the links in this, from links that are attached to this one story about Whitney Brown. So I did 2 more pieces on obstetric care in rural areas, kind of building on the reporting that I had done for this one big narrative. The first is a video that actually went along with the story that I just talked about. It was a very different story. It kind of went back to where I had started, the dearth of maternity care in Georgia. There's a real hospital desert, real maternity desert in the southeastern part of the state, which you can actually see on one of the maps I just showed. I met a midwife, Linda Randolph, who is pictured there, who travels a couple of days a week to Louisville, Georgia, where she runs a prenatal clinic in a town where women, when they do give birth, would have to go about an hour away to Augusta. So I spoke with several patients there. Many don't have cars. One woman said she spent her last $20 on gas to drive her daughter to the hospital in labor. Many of these women also have complications. Some are morbidly obese, hypertension, other complications which pose risk to pregnancy. And then the last piece was on a solution or partial solution to these maternity deserts, which is telemedicine. Some rural clinics and hospitals now are able to tap the help of maternal fetal medicine and other specialists through telemedicine. And this is one kind of groundbreaking project in Arkansas. There are others throughout the country. It's really a sort of a growing area. So this is one look I took at one particular medical need in rural areas, obstetric care. But as Michelle and Katie mentioned, there are many others as rural hospitals close and as the rural patient populations become older and sicker. I mean, I found as I talked to doctors and nurses around the country, their needs were great everywhere you turn, and patients too. A rural hospital closes, that makes it harder for patients with diabetes, for example. If they have to travel further, they don't have cars, they don't have a lot of money to get to doctors. So it's a similar picture. As among the resources I used, I should also mention, aside from Katie's, was, as she mentioned, UNC's tracker, their rural health research program, and it lists. Last time I checked, it listed 95 closures as from January 2010 to the present. That's hospital closures, and so remember that often rural hospitals stay open, but they have to cut a lot of services to stay afloat. So It's not just the closures, it's the services as well. So that's it. Thank you very much. And I'm happy to, I'll leave you with this wintry shot, and I'm happy to answer any of your questions.
Thank you so much, Betsy, and to you, Katie. I just want to share with our audience that if you have a question, please type it into the control panel, and we will be able to ask, you know, as many as we can in the time we have remaining. We have a question now from Caitlin Cross Barnett, who asks, Katie, was access to midwives and licensed birth centers considered in the research? What about other prenatal primary care providers such as advanced practice nurses? And did the researchers consider exploring induction and C-section rates? In other words, do rates go up in order to ensure deliveries at hospitals?
Yes, that is a lot of wonderful questions. Thank you for that that question. So the first part of it was looking at access to CNMs, certified nurse midwives, and to licensed birth centers in rural communities. And then the second half was asking about the outcomes that we looked at, whether we would have looked at cesarean or induction or some of those things. Is that, did I get everything correctly, Michelle?
Yes, I'm sorry, I was on mute. Yes, that's correct.
Thank you. So the first question is around, so let me just say explicitly in the study that we looked at, we did not look at licensed birth centers in rural communities. We looked at hospital-based obstetric services. There are few licensed birth centers are an excellent evidence-based option for birthing services, but for many of the same reasons that it's difficult to keep an obstetric unit open in a rural community, it's also sometimes difficult to keep a birth center open in a rural community. And comparatively, there are, of all the licensed birth centers that exist across the United States, there are fewer in rural communities than there are in urban communities, in part because of the number of patients that are required to bring enough revenue in to keep the doors open. So it's a great potential solution to explore, and it right now is not something that you see a lot of. But that wasn't explicitly included in our data. If someone birthed in a birth center, that would have been listed as an out-of-hospital birth. The question about midwives is a great one. We have a prior study that we did where we, I think I mentioned the nine states where we called up and talked with the hospital administrators and obstetric unit managers at those hospitals. And we actually asked about how many rural hospitals had midwives practicing there. And we found that about a third of all rural hospitals in those 9 states had midwives that were catching babies and doing deliveries. And that was also a place where many rural communities felt that they wanted to grow. I was somewhat surprised by that number, by the presence and prevalence of midwifery practice in rural communities. And it's, there are scope of practice questions that come into play in different states because that's licensed differently across states, but certainly an important aspect of the rural maternity workforce. Finally, the question about cesarean delivery rates and labor induction. Those are great questions and things that I've examined in other data. It was extremely complex, as Betsy has alluded to as well, to get the data that we needed to ask these questions. And we used birth certificate data for outcomes, and because of changes to the birth certificates that were adopted over this time period and differentially across states, we were not able to look at a consistent measure of some of these other service utilization things, and we also weren't able to adjust it for clinical appropriateness of care. So we did not look at those outcomes for a variety of reasons. They are very important outcomes and are things that we should continue to look at moving forward.
Great. We have kind of a related question, or more of a comment from a woman named Lauren Noonley, who says, I'm from Georgia and concur with the sentiments of Betsy. I would like to ask the speakers, how can we ensure services to women and their families in rural areas within the state where some women have to travel 3 hours to their nearest obstetric unit? She goes on to say that during the last legislative session, OBs shut down proposals for the use of nurse practitioners and midwives to cover the shortfall in OB providers. And she says we'll continually have difficulty in changing the trajectory of maternal mortality in the state if this issue continues to be ignored. In other words, this idea of protecting, OBs from incursions by other, nurses, high-level nurses, and so on, in her mind, trumped, sound practice, would be an interesting question to hear your thoughts on.
A couple of things. I did not encounter that in my reporting, but I'm not saying, it's certainly a familiar issue. If you look at the case of Linda Randolph, actually, who is a midwife, and she, started traveling to this prenatal clinic with and this was all set up by OBs. So I think there is some positive movement out there, but it's absolutely true. I mean, it's hard for OBs to be in these very rural areas if hospitals aren't providing obstetric services. So short of that, you've got to come up with another solution. And it really has been a struggle in Georgia for some reason over this. Maybe Katie has some other thoughts.
Sure, I do, and I am familiar with the legislation that the person mentioned. And I think that scope of practice and territory issues are hard, and they're hard in part in the context of financing for maternity care. And when there are few patients, and all the revenue is tied to those few patients, the competition becomes even more fierce, and that seems a little bit counterintuitive in places where you have a shortage of providers. But it's a cyclical pattern where it's connected to scope of practice and financing, and especially Medicaid financing. One beacon of hope, I think, is I will be curious to see how the Improving Access to Maternity Care Act at the federal level is implemented across states. That law basically identifies these maternity care shortage areas and will do so based not just on obstetricians, but also on family physicians that provide obstetric services and certified nurse midwives and midwives that provide obstetric services. So I think that will help the conversation about rural maternity care become more inclusive and less divided by different professional societies and professional groups. I will also say the national professional societies tend to be led by folks who are urban, and that when you get right down to it in rural communities, there's often a lot less, to Betsy's point about her experience working with Linda Randolph, there's often a lot more collaborative in nature, but sometimes the policy dialogue is not happening with those rural voices and interests in mind.
And we have a question from a reporter, Nathan Baker, who says, in our region in Northeast Tennessee, some of which is considered rural and some of which is small metro, our two competing nonprofit hospital systems just merged, with the state commissioner of health overseeing the new operations to prevent the negative effects of the healthcare monopoly. The new system is beginning to consolidate and close services to realize efficiencies. What should I be monitoring? What should I be monitoring to gauge the effects of the merger on our population?
I mean, I think for starters, it's always interesting to see what services are being cut at which hospitals and moved, and where they're being moved. In fact, at one point when we were looking at our hospital cost report data, I identified a kind of a pocket in the Midwest. I'm sorry that I forget which state it was, but somewhere up in Katie's direction, and started asking about it. And a pocket meaning kind of absence of obstetric services, even though there were hospitals there. And it turned out there had been a merger, and so 2 maternity wards or 3 maternity wards had been combined into one. So I think the interesting thing to look at might be where, how many consolidations there are of services and where those services move. So if you're if you're a pregnant patient in, east of Knoxville or something like this, Johnson City or something, how is that going to change things for you?
I think this is a great question, and one of the things that I would perhaps suggest that journalists look at with regard to mergers and consolidations that are happening in rural communities is what is the level of community engagement and consultation around that process? To what extent are folks communicating with their communities? And then what are the community's concerns? And then I think, that helps the process of starting to know where to look. People will know their own concerns in their communities, and some will bear out and some won't. But I think that's a good place to start with looking at investigating what the effects of those closures may be, and also how hospital systems may do things well to mitigate those effects by working proactively with community members to stave off concerns. I mean, one of the things we hear all the time with consolidation of maternity services is when people are located much further away from either their prenatal or their delivery services, they're less likely to go in for their visits, and they're more likely to have a complication on their way to give birth, or just have to do so in a more rushed fashion. And something that can be done is arranging for transportation or keeping prenatal care locally while childbirth is more distant. And there are models that can be successful, but they tend to require some level of engagement with the community as opposed to just dropping it on them.
I have an easy question here from Steve Mencher, who says, how do you define micropolitan?
Betsy, do you want to take that, or did you want me? I'm happy to.
Yeah, why don't you go ahead?
Sure. So the metropolitan statistical areas in the United States are divided as, the first cut is metropolitan and non-metropolitan. So metropolitan are generally considered urban, and then non-metropolitan statistical areas are considered rural. Among the non-metropolitan areas, there are micropolitan, which are places with a and I'm not going to remember the exact number right now, but I think it's a city center of at least 10,000 people. I may be wrong. This is exactly where using that Am I Rural tool that I pointed to earlier is better. But it's basically a non-metropolitan community that has a population core of a certain amount, and then that's what I mean by micropolitan. And it's a classification by the Office of Management and Budget. It's an OMB classification. And then non-core rural areas are areas that don't have a population center of at least that minimum level. Forgive me for not knowing the exact amount. My children would be horrified. We play a game in my household when we drive across a new county line to guess whether it's metropolitan, micropolitan, or non-core. Our family road trips are great.
Only a researcher would play that game. So Charles Dunlap asks, he says, a rural hospital in my area announced it will be ending women and children's services by the end of February. What research is being done now to update results from 2014? How can a journalist bring information? And sort of related question for him is, how can a journalist bring information relating to midwifery in areas that may not have it as something in the mindset of readers and community members?
I think Betsy would agree that it's really, really, really difficult to get up-to-date data on this topic. And I will say, from a research perspective, I wish that we were studying this in real time and that we had resources to do so. It was incredibly difficult and data intensive to get the data that we did get to study this. And it's not consistently recorded and updated anywhere that I am aware of. And so that I know that's not a very satisfying answer. It's the most honest answer that I can give. Betsy may have some ideas about some of the sources, and she talked a little bit about some of the data that she went to. You can go to like the state hospital association and ask for information there. I would also, with regard to midwifery, most states have a chapter of the American College of Nurse Midwives, which is the professional association for certified nurse midwives, that may have data on access and scope of practice, as well as the location of midwives in particular state environments. So those are some resources to go to. I am not aware of any place where this is cataloged regularly and updated.
Yeah, I would agree with that. And I'm sure, Katie, you remember our conversations, me calling Katie over and over and saying, isn't there better data? Where do I get data? It is very difficult. State data, as she suggests, may be easier to get. There's also, and I mean, in terms of hospital closures, UNC's yes. List is pretty current. So if you're looking for the number of closed rural hospitals around the country, that's gettable. Also, certainly CDC's Wonder database is fairly up to date as well. So you can find out about rates of maternal mortality, birth complications nationally there.
It's really hard to get that data down to a local level, though.
It is very, yes.
Numbers. Yeah.
Right. It gets much harder as you get to rural areas. So that's true. And yeah, otherwise, this was these data sets were very, very difficult to get.
Another potential source of a little bit more local data is a resource called County Health Rankings, which has county level, generally fairly up-to-date information on health. Generally, it's not going to be as specific as where a hospital closure occurred, but can give you some some sense of the health and the broad landscape within a county that can be useful context for these stories.
Is that the Robert Wood Johnson Foundation?
Correct. Yes.
Yeah.
And by the way, Jeremy Olson, one of our participants, says micropolitan is 10,000 to 50,000. So I'm going to ask a question on behalf of James Morrison, who says, can you talk about the role of expanded Medicaid? Would this prevent hospital closings?
That is a great question, and there has been some research done on this that I don't have at my fingertips right now. I think the short answer to that is yes. Medicaid is an important payer in rural communities. It's disproportionately the payer mix of hospitals is something that they pay a lot of attention to in both rural and urban communities. And in rural communities, Medicaid is a more common payer than it is generally in urban communities. And so whether or not a patient walks through your door with Medicaid insurance or no insurance at all really affects your hospital bottom line. Are these going to be bills that are going to be paid, or are these going to be bills you're going to have to go try to collect? And that significantly affects the bottom line of hospitals. And again, I know there is evidence in the published literature on this topic, and I don't have it right at my fingertips, but the short answer is yes.
We have a couple of questions about just the healthcare marketplace. Doug Barker asks, have you seen evidence of OB services being dropped for more financially rich services such as cardio or catering to older demographics? And Alan Fenewald says, has the monopolization of healthcare services in rural areas by large companies been an issue in many places? And if so, what have the results been like?
So I think the last question is not something that I have seen a lot of research on. I have gotten a lot of questions from journalists about hospital ownership and privately held hospitals and hospital groups versus nonprofit hospitals, and that's not something that in it's usually not something that I can observe in the data, like who's part of what hospital system, the data that I use. I think it's a really good and important question, and it's I'm encouraged that journalists are asking those questions. I hope it will help us researchers to do work to help answer them, as I think it's really important. And the other question was, please remind me. I apologize.
Sure. The other question was, have you seen evidence of OB services
Oh,
being
yes.
dropped for more
For more
financially
lucrative services. Yeah.
services, cardio, or catering to older demographics?
I think, as Betsy mentioned, what frequently happens before a rural hospital closes is that service lines get dropped. And one of the, the lost leaders, the service lines that get dropped the most frequently are mental health services and obstetric services. Those are just, they're service lines that are very difficult for hospitals to make money on. I haven't seen specific evidence of, nor have I done research on, like whether one service line has replaced another. In general, hospitals will have like more. There's not a lot of adding of service lines to replace one that goes away that I have seen, but that may be part of what's happening. More and more, what we see is people that are that are consolidating their services or trying to find unique ways of being able to keep the doors open and offer services that both that the community needs and that they're able to get paid reasonably well for, to be able to keep those doors open.
Well, we have other questions waiting, but I'm afraid our time is up. I'd like to thank our two wonderful speakers as well as our audience for these excellent questions. Please take a moment to fill out our survey about the webinar and your top choices for future ones. The archived video and slides will be on our website shortly. Thank you so much.